Welcome to Health Focus, where we focus on your health. I'm your host, Dr. Scott Anderson, and we're focusing today on occupational medicine. And we're very fortunate to have with us Dr. Justin Nast. Thank you so much for being here, Dr. Nast.
Great to be here.
It's really a pleasure, and I think we have something in common. I used to be in the Air Force for about 4 years as a doctor, but I believe you made a career out of it.
Yes, I did. I went in the Air Force active duty in the year 2000 after I finished my first residency training in OBGYN, and I served as an OBGYN in the Air Force for about 8 years. And then I decided I wanted to do more Air Force stuff, and they let me become a flight surgeon. So that's a form of occupational medicine where you take care of air crew and other people involved with the flying mission. And I liked that so much that I decided to do another residency in aerospace medicine and combined with occupational medicine. And I did that in the Air Force and kind of never looked back. So it's not like I didn't enjoy OBGYN. I still very much enjoyed it, but I really enjoyed doing the operational part of the Air Force mission, and got into some leadership roles, and then retired after 21 years.
Well, you look very youthful for that, and thank you for your many years of service to the country.
Oh, thank you for yours as well.
And maybe you could just explain, because I think it's a little confusing, what exactly is occupational medicine? Many people have heard of occupational therapy, but obviously what you do, you're doing as a physician. Tell us, what is occupational medicine?
So, having come from the Air Force, I like to tell all the people I worked with and remind everybody and be reminded that all healthcare providers are kind of doing occupational medicine, because in the military, pretty much everything that you do is considered on the job. And so that is kind of the crux of occupational medicine, is that these are work-related health problems that we're dealing with. And occupational therapy is actually a very subspecialized area of physical therapy, where the therapists are working mostly with hand injuries or recuperation from things like strokes and other things that affect somebody's functional ability to do activities of daily living. So we work with occupational therapists a lot, but it's nothing like occupational medicine.
Okay. And in your clinic, as distinct from, for example, being a qualified medical evaluator who sees people and issues reports to just evaluate them, what you do as an occupational physician is actually to treat people and try to get them healthy enough to go back to work. Is that fair to say?
Yeah. So we're limited. The practice in occupational medicine is limited to people who have suffered a work injury. So if they have a primary care problem, say it's hypertension that's not related to their job in any way, then I wouldn't be following and treating them for that. That would be their regular primary care physician. So we get people in our clinic who have suffered a work injury, and we get them for the period of time where either we treat them until the work injury is completely better and we can release them from care, or we treat them until the point where we've done everything that we can, even if they're not fully recovered, and then we make a disposition based on how they're doing at that time.
And your clinic is in Fairfield, and it's associated with NorthBay. Is that correct?
Correct. So NorthBay has an occupational health clinic, and that's where I work. And it's 2 physicians, including myself, 2 nurse practitioners, and 2 physician assistants, and lots of support staff.
And how do patients wind up in your clinic? Are they self-referred? Do their supervisors send them in? What's the process?
So a patient or an employee at that point has a work injury, and then that work injury, they make a claim that they were injured at work, and that goes through their employer. And then all the employers are insured, and so the insurer has to authorize their care to come to our clinic. So for a new injury, we have to be authorized to see them before we can engage in care. And there's lots of different clinics that do this throughout the area. So oftentimes they'll have arrangements with these other clinics as well, and us being able to see people in a timely fashion helps us get the patients in there. We also have agreements with a lot of local employers, for example, the school district we have a relationship with, and and some of the other employers in the area, big and small.
Very interesting. And I believe also if someone does go to see a primary care doctor for a work-related injury, the doctor can fill out a form called the doctor's first report of occupational injury or illness, and then essentially start the ball rolling to be seen by you.
Right. What a lot of the workers don't know, and a lot of the human resources departments don't necessarily know or tell them either, is that they can actually be followed for treatment by whatever physician or provider that they want, except that physician or provider has to agree to it.
Right.
Which a lot of primary care providers don't want to get involved with the system, because it can be complicated and requires some specialized, like, administrative setup with your office. But yeah, the first time they get seen, a lot of people get seen, like if they have a catastrophic injury, they're going to be seen in the emergency room first. They might be hospitalized. So all those people are doing occupational medicine at that point. And then eventually they get handed off to a clinic like ours to continue their care.
I think there's variability also in terms of employers and how they handle these things, wouldn't you say? For example, if you're running a plant and you have a sign up that says 300 days since our last injury or whatever, and if there's some goal that they're trying to reach where maybe everybody gets a free lunch if they get to a year, there could be an incentive to encourage employees not to report injuries. And of course, we don't want that, but I must confess I've seen that on occasion, where an employee will report an injury and the employer will say, it's not that bad, just keep on working. I mean, have you heard these stories as well?
Seen and experienced. So I'll kind of digress so the residency training, and occupational and environmental medicine is a residency that you can do specialized training, and that actually comes under the American Board of Preventive Medicine. So along with aerospace medicine and general preventive medicine. So the focus with these specialties is prevention. So if we can take the harm out of the process for the worker, or in the most extreme cases, take the worker, like a dangerous job, completely automate it so there's no human beings being threatened by this particular work environment, then you've prevented an injury, and you never end up getting to the point where someone's been injured and you have to treat them or they have permanent disability. So, but yes, there's instances where there's, with the Occupational Health and Safety Administration, of which there's California Occupational Health and Safety Administration. California does its own versus federal. There's reportable injuries. So any injury where you lose time at work, you have to be treated by more than just first aid, and a couple other criteria. Those are recordable, and those kind of are a strike against, workplaces and employers if they have too many of those.
Right, and of course, some employers are excellent and very conscientious. It varies from place to place. But I'm glad you brought up your training, because I actually wanted to ask about that. The typical pathway, if you are going into OcMed, as some people call it, occupational medicine, I sort of think of it as being first a residency followed by a fellowship. But the residency apparently could be in any number of fields. Is that correct?
Well, yeah, to go into an occupational environmental medicine residency these days, you don't need any prior. You can just go right in, and actually this will be in the next year. They're going to be available for the match, which is, as you know, is the way that medical students get matched with their training programs, and it hasn't been before. Now, there's not that many programs, but that's kind of a new thing, and expect a better pool of applicants for this.
I've seen the term occupational and environmental medicine. Why is the term environmental added?
So, mostly due to we do deal with things such as toxicology, air quality in the workplace. You can't really separate a lot of some of these jobs from their hazardous environment. If something is related to where the job itself, they have to wear, protective equipment all the time. I'm thinking of like in the Air Force, where the people who are painting the airplanes with a lot of different compounds with potential toxicity. So we're always looking at the environment as well.
Of course, noise exposure is an environmental factor, and
Sure.
also just
radiation.
Right, right. Does doing an occupational and environmental medicine residency then rather than fellowship, does that render a person a toxicologist?
No, I would feel like you do definitely get some exposure to, no pun intended, exposure to toxicology, but you, I would not say you become an expert in that unless you do a fellowship or you've made it a big part of your practice. For example, as part of completion of a preventive medicine residency, you need to have completed a Master's of Public Health or equivalent. Okay. And I know in my Master's of Public Health training I took a toxicology course, but it doesn't make me feel like I'm a toxicologist and I don't concentrate in that area.
Okay, thanks for clarifying that. Let's talk about the workforce. I believe you have a slide that indicates that, well, you could tell us about it, about the work participation rates.
So it's interesting, this slide over time shows people younger than 65 involved in the workforce. And that has remained fairly steady over time. If you look at 65 and older, that has risen fairly dramatically over the last decade or so. And probably one of the main reasons for this is possibly economic. People have to keep working. But what this translates into for me is I'm seeing a different subset of injured workers. So some of these older workers, they have an injury, a fall is probably one of the most common things. As they're not typically doing any heavy labor, but they can still fall, they can still get assaulted at work, and they just don't bounce back like some of the younger workers, and they can be out of work for a longer period of time, which could be potentially catastrophic for them if they're really depending on that income. So it kind of introduces some complexity. But at the same time, these are very attractive workers for the employers because they show up to work on time. They're often experienced. They just have a different work ethic than some of the younger folks.
And among younger workers, what are you seeing in terms of the data of participation in work and so forth?
Well, I haven't seen it drop off, but anecdotally, what I've heard is that it's a lot harder to get some of these younger folks to consistently work at some of these jobs that aren't necessarily, jobs that people want to do. And
right.
And so that's why some of the employers are having to go and hire some of the, older folks.
To older workers. In fact, I think the Wall Street Journal has explored this, and around the time of the Kennedy administration, I think the labor participation rate was the highest ever between the ages of, I believe, 25 and 54, the prime working years, and it was something like 97.5% among men in that era when mainly men worked, although women worked, but not to the numbers we see today. And I believe now the comparable figure is something like 88.5, so roughly 1 in 8 men of peak work years are not working. And as far as the statistics for women, I don't really know those, but it suggests that at least among men there was a big drop-off in labor participation. So that would make sense if you have more older workers coming back to fill these gaps. And obviously older workers do have less physiologic reserve. Let's talk about some specific injuries if we could.
Sure.
Back pain must be a major issue, you see.
Back pain and back injury are the most common things that we see. And this can be, it doesn't have to be someone who's doing like a heavy labor where they are lifting all day. It could even be somebody who is doing relatively light work but just turns the wrong way or, kind of slips and twists their back. And typically these people, it can take 4 to 6 weeks for a regular muscle sprain in the back to fully get better. The problem that we run into is when they start going past that point, and then we have to worry, is there something else going on, either not related to a work injury, or did they actually have an issue with their nerves in their spine itself? And then that involves a lot more potential time off and additional treatments, and some people never fully recover.
So, Dr. Nast, you're trying to get people to recover so that they could resume a normal life and get back to work. Do you use a lot of physical therapy?
A lot of physical therapy. We try to get, if we identify something that we know is going to need physical therapy, we try to request that early on because as in most medicine these days, even though I feel like this person can benefit from that, it still goes through an authorization process with the insurance that can take some time, and by the time they get on board, it can still be several weeks down the road after their injury.
How about prevention strategies? I think as a rheumatologist about avoiding obesity and avoiding cigarette smoking, good lifting mechanics. What's your perspective on preventing back injuries?
So yeah, the most important thing usually is how well the employer has what's usually called an environmental health and safety program, to where they're teaching every employee who comes in, especially jobs where they're doing regular heavy lifting like warehouses and things like that, that they teach them proper lifting mechanics, and they have to demonstrate proper lifting mechanics before being allowed to work, and as well as how to move to minimize the stress on your joints. So those things are all very important for prevention.
Okay. And hernias go hand in hand with lifting injuries, because if you're doing heavy lifting, you can develop a hernia. I think 1 out of 4 men will eventually have a hernia, 1 out of 10 women. So it's very common. You must see hernias.
Yeah, so that's an interesting, because that brings you to one of the main things that distinguishes occupational medicine from just regular medicine. Regular medicine, your patient comes in, you don't worry too much like, did they get this at work? Did they get this, playing baseball or doing something else not related to work? You just treat them. We always have to think about causation. Like, was this just because the patient thinks it was related to work, or even just because the employee thinks it's related to work, does not necessarily mean it's related to work. So hernias, you can get a hernia, as you know, whether you have lifted something or not. Now, if the employee has never complained of a hernia, never had the pain of a hernia, never saw anybody for a hernia, and then one day they're lifting heavy boxes in a warehouse and boom, they get a lump in their belly and they have pain, it's usually pretty easy to say, well, this was probably caused by your job. So we can treat it as a work injury.
I should also, just point out on that topic that in California, where I do evaluate injured workers as in a different capacity as a qualified medical evaluator, there is a labor code section, section 3212, I believe, which affords certain presumptions to employees who are first responders, like firefighters, police officers, highway patrol. And typically for them, if they have a hernia, it's presumed to be industrial. Does that become an issue that you address as well in your field?
Yeah, so that can be contentious at times, because and the part that there's kind of two kind of buzzwords, and you're probably familiar with them too as a QME, called arising out of employment or in the course of employment. Right. So arising out of employment is more on the medical side, where I make a medical decision. From a medical standpoint, does this make sense that this person's complaints, injury, diagnosis, did this come from what they're telling me about their job and what they do for a living? Course of employment is a little more difficult, because then that says, was this person really an employee when this happened, or were they a contractor, or that's not really something that we decide, and that sometimes ends up being decided on a legal basis, when there's contention with that.
Well said. Let me ask you about COVID-19. Are you seeing long-term complications? Are you seeing pneumonia? Or are you seeing the so-called long COVID with fatigue and other problems? So
knock on wood, even though we take care of all of the NorthBay employees who have work injuries, or the majority, they still have the freedom to seek out other care for their work injuries. I'm not aware of any long COVID patients that we are following now. Now, we have definitely had people who have had claims of that they had COVID, related to a job exposure, and those have been difficult to adjudicate, because as you know, COVID's pretty much out in the community, and it's sometimes very difficult to tell, did they get this from work or they've been out in the community, and it's only could be a potential issue if they did end up with long COVID or some persistent symptoms. Unfortunately, most people, that's not the case. I could talk to you all day about this. It's so fascinating, but we're limited on time, so let me change gears just for a quick response, if you don't mind. Sure.
What if you see something that perhaps falls outside of your area of primary expertise, like post-traumatic stress disorder perhaps? Do you refer to mental health providers for further evaluation?
Yeah, so fortunately, I have a wide range of, I could basically request people to be seen by any number of specialists that I want. Of course, the most common people that they see are orthopedic surgeons, since we mostly have musculoskeletal injuries. But yes, I routinely refer to psychologists, psychiatrists, any specialty if it's related, if I think the work injury is related to that particular specialty. Now, sometimes that's a problem when some of the other, say like dermatology, they have to, number one, we have to find somebody who wants to see somebody who has had a work injury. So that can sometimes be a little problematic.
Right. A lot of doctors in the community just don't want to see workers' comp cases for a variety of reasons. Yeah. Vision loss and hearing loss. I think of those as being areas for both treatment and prevention. Can you just say a couple words about that, or a few words? I know it's an enormous topic.
Well, so this is a big thing that was also in the Air Force, because obviously a lot of people work around very noisy environments there. Including when I was flying as a flight surgeon, you have to protect yourself, or you're firing weapons or any number of things. So there are criteria for when a work area must be under what's called a hearing conservation program, where the noise levels are measured on a regular basis, and if they're above a certain level, then that area requires them to wear hearing protection when in that area and get annual audiograms to track if they're having hearing loss. The problem we run into is that there's a lot of work areas that have loud environments but are not followed by a formal hearing conservation program.
Right, and of course, even with education, you have to adhere to the necessary requirements, and that could be a challenge, including personal protective equipment like eye protection. As we begin to close off this discussion, what do you see as the challenges on the horizon and future areas where we can do better as a society to support workers and to support the whole endeavor of occupational health?
I think that the thing that bothers me the most on a daily basis is that always worrying, like, is this person going to be able to get the care that they need for this injury, whether it's determined to be a work injury or not. Some of the people who come to us, they don't have any other coverage, and they're really depending on the workers' compensation system to take care of this problem. And if that problem is deemed not to be work-related, some of those people can have a big struggle trying to get that care. So it's kind of a little bit of a pitch for single-payer system, because then we're not worrying about, it's all the same pot of money. Mm-hmm. That problem is going to have to be solved because costs are ballooning under the California workers' compensation system, and so you have to figure out some way to control the cost, but at the same time still provide the correct level of care.
That's very interesting. Is there evidence that other countries with single payer do better in helping injured workers?
So I haven't. I honestly haven't looked at that, but the issue being that no one's worrying about that if they get hurt at work, that they're not going to be able to somehow, or it would make people more likely to report these injuries or not have to, pretend that this happened at work when it really didn't, things like that.
Right. And is there research in occupational medicine, either retrospective, looking back in time, or going forward? Are there journals that are looking at how we can improve this whole process of preventing and treating injuries?
So there's the American College of Occupational Environmental Medicine, which is the professional organization for the specialty, has a journal. A lot of it is very basic science focused, but there's also a lot about programs. One of the things that comes to mind is like a workplace wellness program where you reward people for maintaining a certain level of cholesterol or not smoking, and then they look and see, is that reduce their overall level of health claims and injury reporting. And unfortunately, the surprising thing is it usually doesn't have a dramatic effect. So there's no magic bullet for...
I guess there are no magic bullets, but we'll keep trying to make small incremental improvements. Where can people turn for more information on either preventing or getting treated for an occupational injury, either in them or in their relatives or friends?
So yeah, that's one thing I always try to do. I always try to empower the employees, my patients, to say you need to take ownership. You need to educate yourself about this process, about your injury. And one of the first places to start is the California Department of Workers' Compensation has a website that's under It's an organization that's under the Department of Industrial Relations, and they have a good FAQ and a good website that'll explain kind of the process from start to finish, and explains to the employees what their rights are as patients under the workers' compensation system.
Very good. Dr. Justin Nast, thank you for explaining occupational medicine to us. We really appreciate it, and hopefully our audience will sort of learn something from this that will allow them to be safer in the work environment, or at least to get treated successfully if they have a challenge.
That would be great.
Hopefully we'll continue this conversation.
Thanks.
Remember, here at Health Focus, we focus on your health. Today we focused on occupational medicine. Stay safe out there. Try not to get injured on the job. Take care of your health, and we look forward to seeing you again.